Try to get everyone out of here on time for our lunch and learns. So welcome to the Dan and Daniela Show. This is our session on gastroparesis. I'm, again, Dr. Dan Lister, your incoming president.
And I'm Daniela Jodorowsky.
And we'd like to welcome you to the gastroparesis session. We're going to go ahead and, do you want to do the case presentation off the front? Or
I guess let's do the case very quickly. We'll do a poll at the end. We'll repeat the case, but just to give a flavor of what you might be hearing about today. So you're seeing a 34-year-old woman with type 1 diabetes complicated by neuropathy, CKD, who's coming to see you for management of gastroparesis. Main symptoms are epigastric pain and nausea. She has severe vomiting. She goes to the hospital every few weeks for fluids. Sometimes she's in DKA. Her other medical history and surgical history is notable for chronic opiate use for low back pain and a history of cholecystectomy. On exam, everything's normal except BMI is 34. And next slide, please. She had confirmed gastroparesis on a scintigraphy with 44% retention at 4 hours. EGD was normal, but she had some retained fluid in her stomach body. Her current hemoglobin A1C is 9.2% on insulin. And her endocrinologist would like to start a GLP-1 receptor agonist for diabetes and weight loss. And so for her gastroparesis, she's been on metoclopramide intermittently and some antiemetics. Next slide. Oh, we'll skip the poll for now.
Okay, we'll bring up our first presenter, Ms. Ellen Stein. She is going to talk to us about a topic that's near to my heart, the pharmacology of GLP-1 agonists and gastroparesis. Personal story, I'm not quite as fat a boy as I used to be, thanks to tirzepatide and semaglutide. I've been on it for about the last year, so I'm very familiar with the gastroparesis side effects, and I'm very interested to hear what Ellen has to say.
Thank you. All right, so I thought I knew a lot about this, and then I started looking it up, and I realized that everything that has been published in the last year is totally new, so this should actually be a lot of fun. So these are all the agents. It used to be just a couple, and now they're all over the place. You've got dulaglutide, exenatide, extended release, liraglutide. I don't know how to say the next ones, but you got a lot of options. And in the last few months, we've heard a lot about tirzepatide, and I'll tell you more about that. So how do they do what they do has come under scrutiny because we thought we understood this, but apparently we have a new understanding. So there's stimulation of insulin secretion in the islet cells, so an incretin effect, and there's some resistance to degradation by these DPP4 enzymes, so it sticks around longer. And so that's how we're getting these longer acting forms. It used to be just a daily dosing, and now we've got weekly dosing. What does it do? Well, it slows gastric emptying, which, as we heard, makes it a little harder to eat as much. It suppresses your appetite, and some people say it improves satiety. They're just not as interested in the eating. They eat just because you need to eat, rather than it being their whole life. It also can decrease inappropriate glucagon secretion, promote beta cell proliferation, and improve glucose control. That's kind of what we think about it, but what is it actually doing? Well, in the studies, they've been very surprised, and so your glucose control, as we know, improves. And as we've heard in the last year and seen every single celebrity shrink magically who hasn't been able to shrink in the last 30 years, it enhances weight loss. But also, it improves your cardiovascular outcomes, reducing your risks of heart attack, stroke, and all-cause cardiovascular death, which is not, I don't think they expected that, but that's what they're finding. And in something that was published, I think yesterday, it also reverses and reduces heart failure severity. There's also renal outcome improvements, so there's reducing decline in GFR, especially in your high-risk patients with chronic kidney disease, and it reduces albuminuria. That's a lot for something to do. So the big to-do of the last year was the anesthesia societies issued a national warning that periprocedural use of these medications can lead to aspiration, and they made formal recommendations which have been implemented in various and sundry ways throughout the country. So the actual guideline says hold long-acting GLP agents for 1 week prior to procedures to prevent more aspiration risk. And then you got your flozonators, and if you haven't been on flozonator nephro Twitter, you can find out more about that. I'm not going to have time to talk about those, but because of the risk of an acidosis syndrome and hyperglycemia, you're supposed to hold that for 4 days prior. Now, at our center, we do just give general recommendations, and here's one caveat. If you haven't seen your patient in a month or two, your patient has already found either internet, Twitter-based, app-based, or primary care-based access to these drugs. Everybody is getting on them, and that is one of our bigger problems that they do. So we give general advice and guidance to everyone about stopping 4 days before your flozonators and stopping a week before, especially your long-acting agents. And this came out from the American Gastro Society, which was a response to the Anesthesia Society, which said basically, maybe we're a step ahead, but we'll have to be cautious and work together to find solutions. And so they have an actual clinical practice update, but you're going to have to work locally and think about these agents, and we'll talk more about why. So this is the summary slide from the recent article put out in Circulation, showing that GLP-1 receptor agonists reduce cardiovascular risk. And they reduce MACE, cardiovascular death, MI, all-cause mortality, heart failure, kidney dysfunction, and worsening kidney dysfunction. That's a pretty impressive list of things. I really hated these drugs when they came out because as a person who takes care of patients with nausea and vomiting, everybody came in with some nausea and vomiting, and so I was really anti these drugs. But after this slide, I don't think I can be anti anymore in the same way that I was, given these tremendous gains that have been seen in these studies. And in fact, when you look at all of these, other than the side effects, your GI side effects, local reactions, and maybe a history of pancreatitis, there's not that much for side effects. You do start at a low dose with most of these and increase slowly over time, and that is the recommended way to get it. But everybody who gets on them does get reduction in A1C, they do get weight loss, and they even get improvements in blood pressure. So when they studied it, what does this stuff do? And they've studied it in a few things. This was an NIH-funded trial done by Camilleri's group, which looked at 3 milligrams of liraglutide with a randomized controlled trial and showed that when the GLP-1 agonists of analogs were administered, you did have slowing of gastric emptying, increasing fasting gastric volumes, stable postprandial gastric volumes, and satiation was increased and calorie intake was decreased, and everybody lost weight, which is great. But what are the motility changes? Well, this was looking at both esophageal and gastric function, and it was published in Diabetes Care, and they showed, again, GLP agents do slow gastric emptying, and GLP agonists do not change esophageal function at 10 weeks. So they took a cohort of patients, and they looked at them over time, and they showed that, in fact, when you look at the reflux component scores, there was a little bit of increase in reflux, but the esophageal motility itself didn't change when you were using this. So esophageal function as measured by esophageal manometry did not change. All right, so what about this more esophagitis? Well, anecdotally, personally, I've seen many patients who have worsening of their reflux when they start these agents, and it's one of the primary reasons that we are called emergently to see a patient. Their glucose control is improved, everything else is going better, but their reflux is terrible. So this was a study kind of looking at that. It was a huge database look back at multiple centers, 6 million patients with diabetes identified and compared, and the type 2 diabetics were on these shorter acting GLP-1 agonists. They had increased risk of GERD and complications such as erosive esophagitis, even stricture, and the development of Barrett's with or without dysplasia. And that was compared to those who were on the longer acting agents. So there's something a little bit different about the daily dosing agents, but this did show an effect that increased reflux. So what else do we see? Well, anecdotally, everybody hears about it, but in the studies, for all of the agents that were looked at in this type, liraglutide, exenatide, and semaglutide, all of them had more nausea and vomiting symptoms, with nausea ranging between 25 to 60% of some patients and vomiting between 5 and 15% of patients. And when you have a lot of nausea and vomiting, that can be a real displeaser for the patients, especially if they're finally starting to get all their other diseases under control. And when you look at versus metformin, I mean, we all know that metformin has some GI side effects, but they weren't quite as intense or severe. So this was an interesting study that was done just in the look at patients who were getting their colonoscopies done, trying to see who had the gastric emptying delay. Well, you can't prep a patient as well, according to this study, if they're on these GLP-1 agonists. And it was a small retrospective review, but this would make sense, right? We're delaying gastric emptying and then trying to force a whole load of bowel preparation through the stomach. It's counterproductive. So in this study, the cases had a significantly lower bowel prep score. And so this may indicate a good reason why we should consider holding the agents before procedures, but it's not the end of the road. So this is an interesting thing, and I think we haven't begun to kind of tap into all of this. But basically, they're saying this is going to cure Parkinson's disease. Okay, now let me walk you through how it's going to do that. So basically, GLP-1, we know they go to the brain, right? It decreases your satiety, it changes brain centers. So it crosses the blood-brain barrier in both a fast and a slow process. And according to these large studies, there is a suggestion that their GLP-1R agonists can restore dopamine levels in the brain, inhibit these dopaminergic losses, and attenuate neuronal degeneration and alleviate motor and non-neural features of Parkinson's disease in animal models and now in human models. And so this goes to the feature that they find that people have loss of alcoholism, and some people report their gambling is better. So something about the dopamine centers of the brain is affected by these. So the goals of your GLP-1 agonists are to improve your symptoms of obesity and diabetes and hypertension, and it does that. We know that people lose weight, and effectively so, on these drugs. But we also know that weight loss is supposed to improve reflux, but in these earlier studies and earlier on in the course, it makes reflux a lot worse. We know that hyperglycemia in our patients with gastroparesis causes severe gastric emptying delay. So these agents should help, but in studies, they also slow gastric emptying. So I think we have more research to do. But in summary, I think we are going to have to start using some of these agents because their cardiovascular risk profiles are so excellent. And it does lower weight, improve glucose control, and hopefully normal glycemia and reduced centripetal obesity will help all of our reflux outcomes. Thank you.
Okay, next I'm happy to introduce Dr. Carolyn Newberry, who's going to speak to us about upper GI procedure considerations using GLP-1 receptor agonists.
All right, thank you so much. And Ellen, thank you for a wonderful introduction to the more practical aspects of managing these drugs, particularly that's pertinent to a lot of us in the room as proceduralists. And this story of how these drugs actually affect safety of anesthetized procedures only is about a year long. So I only have 10 minutes, but I think I'm going to be able to get through all the history because it isn't a very long history. And it's when we first actually started seeing case reports in the anesthesia literature that there was a concern about how these medications affected gastric emptying and therefore increased risk of regurgitation and aspiration events, which obviously are major events and can cause significant morbidity and even mortality in patients. And it was this study here that was published, again, just about 18 months ago, that was a confirmation of suspicions after some of these case reports had come out. And this was an analysis, it was a retrospective analysis, but it was a group in Brazil that was working at an oncological hospital. The anesthesiologists and the GI doctors got together, and they actually trended outcomes on endoscopic exams serially and looked at patients that had retained gastric contents of any time, so any type of solid material. And they also looked at clinically significant liquid contents, and they defined that using a weight-based calculations that our anesthesiology colleagues looked at. And this study looked at 400 patients or so that had come in for endoscopic evaluation. And looking at the numbers here, 33 patients were on semaglutide. This is where we got our initial anesthesia guideline, based on 33 patients. But the results were pretty convincing. They did a propensity-matched analysis based on clinical and demographic factors related to gastroparesis risk. And they found that the patients that were on drug, 24% of them, 24% of the 33 patients, had some degree of retained gastric contents that was clinically significant, and only 5% of the patients that did not take these medications had that same finding. So this was statistically significant. Additionally, the study authors reported that there was an aspiration event. So of the 33 patients, one patient actually had a clinically significant event related to retained gastric contents. And this, Ellen already alluded to, discussion that an anesthesia guideline went into effect of June 2023 of last year that said that we need to start thinking more about these patients. And there was a lot of text here, and I think she already went over some of this, but I'm going to summarize it for you here. Now, based on a couple of case reports and this single study of 33 patients on semaglutide, the recommendation was we should be holding these medications for one half-life to try to help improve motility. And if a patient does not hold the medication, we should consider them as a, quote, full stomach protocol. So what that means for all of us is that our anesthesia team may tell us that we should delay the procedure if it is not, quote, urgent, which led to a lot of discussions, I think, heated discussions in our endoscopy suite in OR last year. Or potentially, if it's available to you, point-of-care ultrasound could be offered to see if there is gastric retained contents, and or provide elective intubation, even if patients have no other risk factors for aspiration, which obviously is also a challenge in like a quick-moving like endoscopy unit, if everyone's getting intubated for their routine endoscopies. And this led to, Ellen also mentioned, the AGA practice update in November 2023, just a few months later, still based on no additional data, just that one study out of Brazil and some case reports that, you know, there was a little pushback of maybe it was a little rash to say that all patients needed to hold these medications across the board. And maybe we should actually be taking an individualized approach, they called it. And it was a very long text, but that was essentially the messaging. And there was concerns from the endocrine community and for those of us who use these medications for insulin resistance, that cessation of these medications for patients, particularly that were diabetic, might actually provide more risk than benefit. And so we really need to start thinking in a more individualized way. Problem is individualization in a big healthcare system of, you know, open access procedures and things is very challenging. And so we really needed to have more studies to say what to do for patients clinically. And so in 2024, we got a couple of those studies. The first one that came out was a database study of a large database, you know, millions and millions of records, 80 facilities. The group out of Cedars looked at adult patients undergoing endoscopy over a 2-year period, so 2018 to 2020. And this was a time when these medications were not approved for obesity. So all these patients, in theory, have diabetes who are using the drug. And they compared patients who were on GLP-1s, defined as having a prescription for at least 6 months that they refilled twice, so in theory they're taking it, versus patients that were not taking it. And it was big numbers that this group was able to analyze. And here's the data here. It might be a little small for you to see, but I want to show that they showed that there was a statistically significant increase in risk of pulmonary aspiration in patients who were on drugs, but the overall risk was still very small. So the reported number was 0.83% of patients had a pulmonary aspiration event if they took the medication, and 0.6 patients had it if they weren't on the medication. So statistically significant, absolutely, and a major event, but this was still a very, very rare occurrence, and that is listed here. You can also see when they break down by reported gender or even type of anesthesia that's used, a lot of this statistical significance washes out. Additionally, they noted that if a patient underwent a lower endoscopy, so a colonoscopy, the same day as their upper endoscopy, the liquid prep and the bowel cleanse actually also washed out clinical significance of this finding. And other groups came forward. This was a study published out of the UNC group and CGH that didn't find actually increase in pulmonary events. And I'm just highlighting the composite pulmonary adverse event here, which they defined above: aspiration pneumonia, respiratory failure, et cetera. And there actually wasn't increased significance in patients that were on medication versus their control group, which was utilizing another diabetes medication. So patients that were sick enough with diabetes that they needed a medication for disease modulation. And there was more studies after that. So again, 2024 was a good time to really try to bring the science to practice. This was a study out of the WashU group that was a much smaller study. Let's see. 300 patients, but it looked at patients who were matched with controls based on age, gender, diabetes status, other pertinent medications that may slow gastric emptying. And it did show there was an increase in retained gastric contents, which I don't think is necessarily surprising, considering what we know about the medications and their mechanism. But there was a difference between diabetic and non-diabetic patients. So probably risk factors are related. And again, the actual risk of pulmonary aspiration, which what people are nervous about, is still extremely rare. And it may affect, what patient actually, their clinical and demographic factors may actually affect how much risk this even is. Our group at Cornell also looked at this question. We had a slightly larger cohort, about 600 patients, that were matched with controls that were not on drug by the same factors that the WashU group had used. And you can see that we again showed that there was increased retained gastric contents. I think this has been pretty consistent across the literature. But clinically, what does this mean for our patients? We also showed that same-day colonoscopy, so patients that were on a liquid diet the day prior with bowel preparation, had that statistical significance wash out. So this was protective even when they were continuing the medication. And I think this just in summary, sort of how we are counseling our patients clinically are that the type of diet prior to procedure matters in addition to a medication hold. And I would actually argue the medication hold clinically is probably not as helpful, because if you're holding a long-acting medication for one half-life, the likelihood that this is greatly reducing the motility effects of that drug, I think, is pretty low. And I'm going to fly through this just for time's sake, and because Ellen did such a nice talk on the motility effects of these drugs. But what should I be doing in my institution? I mean, I think this was really the reason why the people that organized this conference asked me to come speak about it, is that I think that we potentially, and we've done actually this at our own institution, is that we need to start considering prolonged fasts in these patients, potentially at least 24 hours, maybe longer if they have risk factors for gastric retention. And many patients, particularly those that are not using these medications for diabetes, but also probably likely those with well-controlled diabetes, can continue their medications. And I put exceptions here because I think it's going to take some time really to get this into clinical practice. These studies just came out. This is hot off the press. And patients that are having significant GI side effects from them, and also our anesthesiologists are going to drive a lot of these protocols. And while they have an official guideline that says that you should hold the med, I think they're going to have a hard time saying it's okay to continue it. But I think all of us as proceduralists need to continue this conversation so that we can help best take care of our patients, avoid unnecessarily cancellation of procedures, elective intubations, et cetera, and really use the science to drive what we're doing clinically. And with the last 6 seconds, I'm just going to provide some summary here, that we know these medications now are effective, but they delay gastric emptying. It's one of the mechanisms. And their effect on anesthetized procedures, the data continues to evolve. But I think that we are seeing that absolute risk associated with these medications are still quite low. And prolonged liquid fasting likely mitigates effect even in the setting of a medication discontinuation. And so we need to continue to engage on this conversation. With that, and individualized approaches are very important.
Next, I'd like to bring up Douglas Adler. Dr. Adler is the medical director of Pig Gastroenterology here in Colorado, and Advent Health. And he's going to talk to us about when to use G-Point.
Thank you.
Thank you.
Thanks for having me. Really appreciate the invitation. It's sort of funny that I'm up here because I am one of those people who left skid marks running away from gastroparesis patients for the last quarter century. But in the last couple of years, I've had a real change of heart because our technology has changed and our abilities have changed. And now I actually embrace these patients and actively look for them in my practice. Who says that about gastroparesis? So gastroparesis has been and really remains a devastating diagnosis for most patients. These patients are significantly debilitated by the disease. Their lives are dominated by nausea, vomiting, abdominal pain. Their whole day is built around what they can eat, what they can get down, when they can eat. Are they near a bathroom in case they have to purge themselves because they feel bad? We do have a wide range of etiologies. I will tell you that in my practice, I see about half diabetic gastroparesis, about a third post-surgical gastroparesis, some post-viral, some idiopathic. We see a fair number of patients who feel that they developed their gastroparesis post-COVID. So all these people get started on diet and lifestyle modification, and for about 5 or 10% of patients, that is enough. Most patients don't want to eat 6 meals a day or live on a liquid or a semi-liquid diet. In the United States, we have Reglan. We also have prucalopride, which is also used to treat gastroparesis. And these drugs, their use is limited significantly by the side effects, and I'll talk about that in just one more second. We used to do a lot more pyloric Botox, and the idea was that you could paralyze the pyloric sphincter, it would stay open, and theoretically reduce resistance to gastric outflow. But enthusiasm for pyloric Botox has waned, although it is still done in some patients. And then there are gastric stimulators, which are also sometimes referred to somewhat incorrectly as gastric pacemakers. These are typically sort of used when all else fails, and in most centers they are at the very, very end of the algorithm. In practice, they are often difficult for patients to obtain and difficult for patients to maintain, especially if they move to a new area that's very, very difficult for them to find somebody, anybody, who is willing to manage their gastric pacer. GPOM, which is exactly 10 years old now and is still in relatively limited use, offers essentially an endoscopic pyloromyotomy. This essentially can replace surgical pyloromyotomy or pyloroplasty. It's critical to understand that GPOM does not treat gastroparesis. It does not make their contractions more frequent, and it does not make their gastric contractions stronger. It reduces a barrier to gastric emptying. So I always say this to the patients, they still have gastroparesis, right? They read on Reddit, they read on Facebook, and they often come with very, very artificial expectations of the procedure, right? So they think that they're gonna spring off the table and go to Golden Corral, right? They're not gonna go, nobody should ever go to Golden Corral, but these people are definitely not going to go to Golden Corral. There's the Gastroparesis Cardinal Symptoms Index. You can find this online. There's a couple of different versions of this. Patients often find this helpful, and if you're doing research studies on this, it's actually helpful because you can quantify responses to various treatments for gastroparesis. This is sort of what it looks like, and everybody does this a little bit different. You can do it on the greater curve or the lesser curvature. This is a mucosotomy where we're making an initial injection and incision into the gastric mucosa, and we're injecting an injectate to create a large submucosal cushion, which we then make a fairly large incision. The entire endoscope with a cap has to fit into this space. So the incision is typically about, 5 or 6 centimeters. And you can see that's done with an RBT knife there. And then here we're just sort of widening that space. We're sort of working our way through the submucosal tissue, which is sometimes referred to as alveolar tissue. And just sort of piecemeal, you sort of make a space for yourself to work, constantly infusing the injectate, and just very, very delicately, millimeter by millimeter, just dissecting out that submucosal tissue. It's actually quite fun to do this part of the procedure. There's a little bit of a zen to it. It's just as you sort of work your way down to the pylorus. And then here you can see we've exposed the pyloric musculature. So we're doing this on the lesser curve, so we're at the 12 o'clock position, and you can see about a 90-degree arc of pyloric muscle that's been skeletonized there. Below that, at the bottom of the screen, is probably the submucosa of the duodenal bulb. So if I kept going, I'd eventually wind up in the duodenal bulb. And here we are doing our pyloromyotomy. The procedure is very, very fast. It's very, very efficient. And I do these as outpatients. I do not admit these patients. They go home the same day unless there's any concern for an adverse event. Many people with gastroparesis have a hypertrophic pylorus, and you often have to cut through the muscle in layers. Again, you can kind of get a sense there that we're working our way through, and the muscle separates very nicely. And you can literally see during the procedure the differences in the pylorus. The pylorus will open much, much wider following a G-POM than it ever could following Botox injection. And then this is sort of how it looks when we're done. And you can see that muscle has been completely transected. Oh, sorry, there's a few fibers there that I'm just cleaning up. The next video is the completely transected. You don't have to get every single fiber. It's often very hard to get every last possible fiber, but you really should try to get as many as humanly possible. And then this is what it looks like when we're done. We're just sort of backing out of our tunnel, and there you can see that mucosotomy and the tunnel. And we simply close this with endoscopic clips. And then this is the final appearance. And like I said, we send patients home same day. So we book these for a 1-hour slot, and it usually doesn't take that long. So we have good data now from our group that so far we have 3-year long-term data. That is the longest data that we have on gastroparesis outcomes. And there's about a 75% clinical benefit that holds up on the GCSI at 3 years for clinical success. Technical success is about 98%, so that's really, really important. This study showed that there was data on hospital stay, but again, we are not admitting our patients. If you compare G-POM to surgical pyloromyotomy or surgical pyloroplasty, they are exactly the same in terms of essentially improvements in GCSI and other parameters. So these are equivalent and it makes sense that they're equivalent because they're doing the exact same things. You're doing a complete transection of the pyloric muscle. What about G-POM versus gastric stimulators, which again, sometimes we still refer to as pacers? This was a retrospective study of 111 patients, but the long and short of it is that people did better following a G-POM than they did following a gastric pacer or stimulator placement. We just recently had this article accepted in GIE, and this was a systematic review and meta-analysis looking at outcomes in patients with gastroparesis by etiology. And I think we were really expecting that some etiologies would respond better than others, and that actually wasn't true. And it actually turns out that G-POM is safe and effective irregardless of etiology of gastroparesis. So that's very, very helpful to know. So there are still many unresolved questions about G-POM. Do patients need intra-procedure antibiotics? Do they need post-procedure antibiotics? Is cutting the pylorus at more than one location, right, around its circumference better than cutting it in one place, i.e. single versus double myotomy? Should you approach the pylorus on the lesser or the greater curve, right? And different people do this different ways. Should you admit the patient or send them home, right? There's almost no data on that. Should people stay on or discontinue, right? If they're on Reglan, should they stay on or get off the Reglan after the G-POM, right? There's very conflicting evidence and a lot of voodoo about prior Botox, and some people do believe that prior Botox makes a G-POM technically harder. I'm not sure that I believe that at all, because I will tell you about 80% of my patients have had prior Botox, and we don't see an effect in terms of difficulty or outcome, but some people believe that very strongly. And then is it worth doing an endoflip before and afterwards to measure the compliance and diameter of the pylorus, right? That adds time and cost. Is the juice worth the squeeze? So again, in 2024, G-POM appears to be safe and effective for the treatment of gastroparesis. We have limited long-term data. The procedures only existed for 10 years, but we have good 36-month data that appears to be very, very positive. We know the procedure works across all etiologies, and it is comparable to surgical pyloromyotomy or pyloroplasty. But I imagine in the coming years you will see a lot of prospective trials looking at trying to tease out exactly where this fits in and what's the best technique to do it. Thank you guys very much, and thanks for the invitation.
And to close out our session, we're going to have Dr. Michael Awad from WashU come and talk to us about when to use gastric neurostimulators.
Thank you, Dan. Thank you, Daniela, and thank you to Reg and Mike for the opportunity to present today. So we'll kind of present a little bit of a contrasting view to the prior talk. And in our center, we do a lot of poems and then subsequently do a lot of G poems. But I have to say that we have actually pivoted now. And in our center, gastric electrical stimulation has become the first-line therapy for patients with medically refractory gastroparesis. The big caveat to that, or note, is that proper patient selection is key. Capital, bolded, underlined. This is very, very important. We'll talk about what that is. Just a quick review. So gastric electrical stimulation, the brand name of the product approved in the US is called the Entera device. It involves a generator that's implanted under the skin. There are 2 leads or electrodes that come from the generator that go to the antrum of the stomach. And then there's a programmer that's used by a provider in the outpatient setting or in the operating room to activate the device and to modulate the setting. It is considered a humanitarian use device by the FDA, and it's approved for patients with intractable nausea and vomiting with gastroparesis in that age range. There are very specific criteria about where the device is to be placed. So specifically, and this is a video, it's 10 centimeters proximal to the pylorus on the anterior wall of the stomach. It's got to be, this is a suture that we use to kind of mark that out. That's measured at exactly 10 centimeters. We do use a robotic technology just to facilitate precise placement of the device. There are these ski needles that we use to tunnel the electrodes, specifically in the muscularis layer of the gastric wall. We do intraoperative endoscopy to confirm that the electrodes do not traverse the mucosa. They also can't be too superficial, so you don't want them right under the serosa either. So they have to be very, very precisely placed within the gastric wall. There are 2 leads placed perpendicular to the axis of the organ of the stomach and parallel to each other again, and this has been mapped out as to where the best efficacy is. We also then attach the programmer to the leads. We check the impedance to make sure it's within range. And then once those 2 checks are done endoscopically with the programmer, then we secure the leads in place with sutures to the stomach wall. We conclude the laparoscopic part and then implant the generator in a subcutaneous pocket. How does it work? Well, in short, we don't know. There's a lot we don't know about the kind of the brain-gut axis, but we think that it works in a variety of these mechanisms, both with gastric accommodation, the interstitial cells of Cajal, which are thought to be primarily disrupted in patients with gastroparesis, vagal innervation, and again, this kind of brain-gut axis. Now, the big question is, does it work? There's been a lot of studies on gastric electrical stimulation, including 5 prospective randomized control trials over the years. I won't have a chance to talk about all of these, but I'll pull out a couple of them. This was done by the McCallum group in 2010 and 2013, first with patients with diabetic and then idiopathic gastroparesis etiologies. And they're very elegant studies. They involved patients with an Entera device implanted, and then they were randomized to having, initially they were all on, and then they turned them off in half the group and turned them off in the other half of the group, and they didn't know which was which. And then they had a crossover study design. And they showed that there was a significant reduction in patients both with diabetic and idiopathic gastroparesis in mean vomiting frequency, significant reduction in hospitalization days, as well as total symptom severity scores. And then fast forward to a little bit more recent studies. This, actually a couple of them were done in France, and they have, again, large national registries that they can tap into with these studies. So again, it was a prospective, double-blinded, randomized study where they took 172 patients with the device on or off, and they found significant reductions in mean frequency of vomiting, both in diabetic and non-diabetic devices. And then this was also out of France. There's a single center study, but with very long-term follow-up, at least 10 years, where they implanted the device and they followed up with a little bit different score that they call the Gastrointestinal Quality of Life Index score, but kind of same parameters as the GCSI. And they found improvements in this score, but interestingly, at 10 years out now, 80% of these patients still had significant benefit and were satisfied with their device and its effect. So I want to talk a little bit about our center, and again, I think one of the things that we emphasize is it's important to have a lot of tools in the toolbox. And we do GPOMs, we do pyloroplasties, we do gastric electrical stimulation as well. But the key is to have a multidisciplinary approach. So it's not just kind of somebody hands them off to surgery and then that's it. We still involve our gastroenterologists, our dietitians, behavioral team, psychologists, and endocrinologists, pain management team. It's really got to be a multidisciplinary approach. We have very, very strict criteria for patients to get gastric electrical stimulation. So they have to have had exclusion of mechanical causes, of course, by upper endoscopy or other studies. They have to have a 4-hour solid phase gastric emptying study, not 2 hours, but 4 hours, because we do know that some patients have some delay at 2 hours but can catch up later. So it has to be 4 hours. And very importantly, and this is hard, they have to be off of all opioids, all THC, marijuana-containing products, and now off all GLP agonists for at least 2 weeks prior to the study. And then, kind of akin to our bariatric colleagues, we have to have 6 months of monitored medical management, which includes all of the above dietary, behavioral, medical management. And we don't just consider Reglan for a week as adequate medical management. They have to have at least 2 prokinetics, at least 2 antiemetics, and cessation of all the above mentioned agents during this time period. So again, we have very, very strict criteria, and they cannot be smokers. Smokers, any nicotine products, gums, vapes, and so forth have to be excluded because we know the device works less well in those patients because of the vasoconstrictive effect of nicotine. Only then can they be considered surgical candidates. So you can see very, very strict criteria, and this does filter out a lot. Towards the aforementioned comment by Dr. Adler, otherwise you can open up the floodgates for a lot of patients that really would not be good candidates for this. So considerations, so again, in our practice, if they meet all those criteria, we do consider the Intera as first-line therapy for medically refractory patients. But what I tell patients in the clinic is some very, very important expectations. This is not an instant fix. We do have to be willing to see each other. And so compliance can be, if compliance is expected to be an issue, and in the Midwest, we have patients coming from a 5-hour catchment area. If we cannot see each other on a regular basis, this may not be a good choice. It also takes 4 to 6 months of adjustment. So this is not just a set it and it's all of a sudden working, and that's also really important. There is a battery inside that lasts 5 to 7 years, so I even see them back once a year, even when the device is working, to check on the battery and make sure that we're not losing track of them. There are some issues with MRI. It is now approved for head and extremity MRI, not for torso as of yet. You can't have nickel metal allergies, and again, some demographic exclusion criteria. So we just published our recent outcomes with our long-term follow-up with gastric electrical stimulation. We do keep a prospective database with these patients. There were 157 patients in this database that had at least 5-year follow-up. And won't go through all of this. Is published in the Journal of American College of Surgeons. About 60% of them were idiopathic, about 36% diabetic, so a little bit different group than Dr. Adler's patients. A lot of these patients have been suffering with this for years before they get to our attention. And again, won't go through all of these. These are the GCSI kind of subscales and scores, again, higher scores being worse. But in general, we see a reduction from 3s and 4s preoperatively to scores kind of in the 1 range, both at 1 year and sustained at 5 years. So we're really excited to see both short-term and long-term benefit for these patients. Other clinical outcomes that we saw is a reduction in a lot of the medication use as well. And this is why it's really important to stick with the gastroenterologist and partner with other providers so that we can have them work on reduction or elimination of some of these medications if possible. And again, we are happy to see long-term satisfaction with these patients. 80% at 5 years are satisfied with their gastroparesis symptom relief. We also talked about hospitalizations, and this is very important. This is not just a huge impact on the patients themselves, but on our healthcare industry, on our utilization of resources. And so we saw a dramatic reduction in the number of hospital days, overall hospital days per patient. And again, this was sustained at 1 year. So this is what we're really excited about. Compared to GPOM, we also did see, by the study Dr. Adler referred to, this is a prospective trial looking at what they considered clinical success of GCSI is at least a 25% decrease in 2 of the subscales at 1 year. Using these same criteria, in that group they found 56% clinical success rate. Using those same criteria, we would see 90% success rate at 1 year. There's a lot of neat things coming down the pipeline with Intera. There's a smaller device coming. It's expected to have Bluetooth in it, which will be nice for patients to be able to monitor this remotely. There's a new programmer coming as well to replace the Palm Pilot era programmer that's currently being used, and some TU technology with leads. So again, gastroparesis is a multifactorial and a multidisciplinary approach is key. Surgical intervention is reserved for patients that are refractory to more conservative management. And again, for properly selected patients, gastric electrical stimulation has significant and sustainable relief. Thank you.
Okay, so those are amazing talks. Let's put up the poll. So just to remind you about the case, it was a woman with diabetic gastroparesis, high hemoglobin A1C, also on opiates for back pain, coming in with epigastric pain, nausea, vomiting, frequent hospitalizations for hydration. Her endocrinologist would like to start a GLP-1 receptor agonist for her diabetes and weight loss. And so is the poll, can we get the poll on the screen? So how would you advise the patient's endocrinologist here? A, absolute contraindication, she has gastroparesis. B, let's start it. It might improve her glycemic control and her weight, which will then ultimately improve her symptoms. C, you have to have a careful risk and benefit discussion with the endocrinologist and the patient to inform decision making. Or D, I'm a surgeon, I don't want to make decisions about medications.
D. It's like something big D.
A couple people.
Okay.
A few honest ones.
Are there enough? Yeah, I think most people, I mean, it's a pretty obvious answer that there has to be a careful risk and benefit discussion. Wanted to ask our speakers if they had any thoughts on this question.
I used to say absolutely not, go away, that's ridiculous, and now we're going to have to start. I think dose-related symptoms are the nausea and vomiting, so maybe they cannot push the dose, but they might be able to get on a lower dose if that's really necessary. But if I remember this case correctly, there was a whole bunch of other stuff that you could do to make her life better, and then think about this. It's not an emergency to add it on, although maybe next week we'll find out that it's the first line before CPR, you give somebody a GLP-1. I don't know. But for right now, you have the time to work with the patient.
I think there's some things with this particular case that I would be concerned about, like the type 1 diabetic who's poorly controlled, who's symptomatic. I mean, I'd have a lot of hesitancy. I think there are probably other options for this patient's diabetes control before the GLP-1. With that being said, there's so much, as Ellen alluded to, that we can do to optimize tolerance of the drugs, really slow up titration, making sure they're working closely on dietary and lifestyle modifications, maybe giving them, a PPI, anti-nausea medications, a bowel regimen. So it can be done, but there are certain facets about this case that would make me nervous.
So in a patient that has had a GPOM, that is still having symptoms, because as you very eloquently put it, you're not fixing the gastroparesis, you're just opening up the outflow. What role in combination therapy with gastric stimulation do you ever use that?
So if people recur, like if their symptoms don't improve to the point where they would like, or they get better and then they get worse, we will often see if they want to add a promotility agent if they haven't been on one, or we will consider them for a gastric pacer. The other thing too is we are in Colorado, and marijuana is king in Colorado, and there is a lot of surreptitious marijuana use. So we actually spend a fair bit of our clinic trying to find out if they are telling us the truth about marijuana use as well, because that can obviously significantly worsen symptoms. So I don't want you to feel like we're anti-pacer. I just feel like I think it's a difficult pitch to the patient to do that before a GPOM, because if the GPOM gets them where they need to go, it's one and done, right? Without a medication, without battery checks, and like I said earlier, God forbid they move. So I think that's a bit of a heavy lift.
Mike, what do you think?
Yeah, I think GLP-1s has just been this kind of new element in the world of gastroparesis, and it's tough. And I think, as the previous speakers discussed, it really has to be tailored to the patient, the setting. For example, in diabetics, they certainly can reduce or improve diabetic control and glycemic control, and A1Cs can drop, which again can help gastroparesis management. But conversely, we've had some patients that have just been phenomenal responders to gastroparetic therapies, and then they're put on a GLP-1, innocuously or not, by their primary or other provider, and their gastroparesis symptoms just come rip-roaring back. And then we're now kind of like 6 months behind, where we used to be, and then catching up again. So it's very, very challenging situation. I think has to be customized to every patient.
And there's a lot of pressure. I think patients are seeing this from their friends, from their family, in the news, every time they go online, on social media. I mean, like people are literally inundated. And if you look at it one time, the algorithm's going to keep sending it to you again and again and again.
Yeah.
Let's look at the second poll question.
I think it's going to send it to us just because we're
Right.
all talking about it right now. Their AI is listening.
So what would be the next step in managing this patient's gastroparesis? Would you choose continued medical management, which includes opiate discontinuation, refer for a GPOM, refer for a gastric stimulator, a combination of all of the above?
How can we do all the above?
See what people think.
It's pretty good.
So grab your Whova app and
Are you a GI or a surgeon?
GI. But I take care of all the pacers. So.
So it looks like the majority are saying medical management, but the next majority is all of the above, or some combination of the above. Thoughts?
I mean, you have to talk to your patient about what else is going on, but I find, not being a surgeon and on one side or the other, that some patients really respond amazingly to a GPOM. If they have more outlet dysfunction kind of stuff and you open the outlet, it works great. If they have more sensory type of stuff and their nausea is what's driving them insane, but their emptying's not that terrible, then a pacer or a neurostimulator will work. And there are people who need another poem because they had their first one and maybe it was done early on and it wasn't as robust as you guys are comfortable doing now. And there are people who didn't respond to a pacer before because they didn't do this really technically correct placement early on. So I have lots of people who are completely better. I just think we tend to, they're so symptomatic and we're so not great at helping them that, and as you showed, both of you, that there are still symptoms years out. There's benefit, but there's still symptoms. So I think we might not be going far enough to help really reduce symptoms early on effectively.
Phil?
Yeah.
I can't help but comment, again, in a very stimulating discussion, that as our ability to evaluate esophageal function has expanded, we are mired in a world in which we use one test that has limited reproducibility and is promulgated by a very small group of people, doesn't measure liquid empty, against of which all of our data are measured, and a instrument that, while validated, has very, very mediocre reliability when you actually look at the original studies from the early 2000s by Dr. Ravicki. So another ripe field. And by the way, I'm not sure that retained gastric contents is a legitimate proxy for complications, because I've been doing endoscopy for a long time, and I don't really think it's the problem.
Okay, we got time for one more question, and then we'll go to our lunch and learns.
Hi, I'm Catherine Hudson from New Orleans. I'm a gastroenterologist, and I'm board certified in obesity medicine. And so I think GLP-1s are amazing, and they're pleiotropic, and they're going to do so many more things even than what you mentioned, which is great, but it's a double-edged sword. And so even the data that drove the anesthesiologists to make those recommendations in the first place, while it was limited, obviously there's problems there. And then the GI societies got together and said, no, there's no problem. We know there's a problem, and we know we're going to go back and forth fighting with anesthesia about whether to cancel, whether to intubate. The original recommendation by anesthesiologists also included, like you mentioned, gastric ultrasound. And in our practice, we have implemented gastric ultrasound whenever those issues arise. And it's been really interesting because the anesthesia team sort of trusts us to make joint decisions about what to do with those patients. And we also looked at some data, and just like the study that Dr. Newberry mentioned, it seems to be the patients with diabetes who have more retained gastric contents. So I think we're going to see some different recommendations in the future. We know we need more data, but as proceduralists, to protect our patients and protect our procedures, I think gastric ultrasound is a great, cheap, fast, easy bedside tool.
I think definitely there's a role for gastric ultrasound. I think the problem is that it's very operator dependent, and we've seen that we've also implemented in practice, particularly when these guidelines came out last year. And additionally, it's just resource intensive to have the ultrasound, have the anesthesiologist or whoever's doing the exam available, and so there was a lot of delays in getting cases done. So agreed, there's many more questions to answer about this topic, but just coming up with like better protocols for whether it's risk stratifying patients, who needs to hold their medication probably longer for a week too, more than one half-life, and who needs to be on prolonged fasting is going to be the option to have the most safe procedures.
All right. Thank you all for another wonderful session. Mike?
Just to remind you guys, it's time for lunch. We have some great lunch and learns available. There are still spots for the Regeneron talk in Adams D, so you can go right there if you want, and it's conveniently by the restrooms, which you may want to use as well. Also want to remind you that the poster presentations are taking place starting at 12:20, and that's in the room where our sponsors are. So we'll see you back here at 1:30. Please